I'm going to talk about schizophrenia. There's a lot in this chapter. I have the book open actually as I'm giving you guys the PowerPoints and going through them. And I want to really pull out the key points so that you don't spend too much time digging too deep. This is one of those disorders that we could have an entire 8-week class, probably a semester, probably a year. There's people who dedicate their whole life to just studying schizophrenia. So I want to try to just give you an overview and help you understand what the takeaways are. It affects 1% of adults, and it is characterized by psychosis. So what's psychosis? A break in reality, right? They're having hallucinations, hearing voices. So psychosis is that break in reality. It often develops gradually, and we usually see it in young adults, very rare in children or in older people. It's usually in that sort of prime of people's life, which is always sort of heartbreaking. It's often believed to be genetic, some sort of genetic component, and it's usually more males that we see it in. The one thing I want to talk about before I remember the DSM-5, we're going back to that. And if you go in your book on page 192 and 193, they talk about schizophrenia being a spectrum of different disorders. The one we see a lot in clinical is schizoaffective, and that's when it comes kind of hand in hand with a mood disorder. And so we're going back to that whole idea that everything isn't black and white. We also have lots of overlap going on. However, the DSM-5 criteria would say that for more than a month, you need to have delusions, hallucinations, disorganized speech, catatonia, which we'll talk about in a little bit, negative symptoms, and we're going to go over the difference between avolition is sort of lack of motivation. We're going to go over the difference between negative and positive symptoms of schizophrenia. That's something I want to make sure you understand. And then you need to see it last for more than 6 months, because think about certain drugs you take could cause a lot of this, or being drunk could cause a lot of that. That doesn't mean you have schizophrenia. However, we will get into a component of how alcohol and drugs can play into it, which is actually quite scary. I remember we said it's very rare in children, 1 in 40,000. When you look at epidemiology, which looks at the rate and the incidence of disorders, there doesn't seem to be a difference between rate, social, or culture status. However, we usually are seeing this more in males and in urban areas. I don't know why. Comorbidity. What does comorbidity mean? You guys know what that means. Like what often occurs with it. Substance abuse disorders, and they seem to be a correlation between nicotine dependence. So think about that, smokers, and substance abuse disorders. And why is that? Are maybe people self-medicating for symptoms they're starting to feel? I don't know. It's hard to know that whole idea which came first. Polydipsia is really interesting. They see this in up to 20% of patients who present with schizophrenia, and they have this excessive thirst, which leads to hyponatremia, which, as you know, remember hyponatremia is that water intoxication. So you have low salt inside your cells, brain cells, and that causes hallucinations and issues. So again, we're in this weird cyclical, cycle. Is it the polydipsia causing hallucinations, or hallucinations causing polydipsia, which then leads to that? Your takeaway as a nurse is that you want to assess a patient for polydipsia who is possibly presenting with schizophrenia, and probably draw some electrolytes and look at their sodiums. Why does it happen? What's the etiology? What's the why behind it? Who knows, right? We know it seems to be multifactorial. Many, many things seem to contribute to this, like everything. There seems to be a genetic predisposition. There's this idea that it has to do with how your body regulates dopamine. And so we know that they discovered this as evidenced by, that's what AEB I wrote, of the first generation antipsychotics, which we'll talk about in a little bit. They're called your typical antipsychotics like Haldol. And what they do is they block dopamine. They're dopamine antagonists, and they reduce symptoms. So that led people to think from a neurobiological standpoint, it has something to do with dopamine. However, we found that amphetamines and cocaine can induce psychosis in patients with schizophrenia, as well as bring on the disorder. So you may have someone who's never been diagnosed with schizophrenia, goes ahead and tries cocaine, and now they have lasting symptoms that don't go away. We also know that certain drug use, particularly marijuana, can increase the risk of schizophrenia in biologically vulnerable individuals. I think, oh, geez, sorry. I don't know why that happened. Stop. So let me get rid of that. That's really important when you're thinking about education for teens, because if you have a family history of schizophrenia, you may want to be incredibly cautious with how you experiment with drugs. And just because something's legal doesn't mean it's safe for you, especially if you have this predisposition. Is it environment? Who knows? Is it you have this genetic factor, but then you're exposed to something in the environment that triggers it? You can look in your book. There's lots of brain structure abnormalities they see when they do MRIs of people with and CAT scans of people with schizophrenia. You don't need to memorize those. It's just an awareness that there also seems to be, again, this is multifactorial. There also seems to be a change in how the brain is working. Again, these are all different kinds of other types of etiologies, things that can contribute to why, prognostic considerations. It seems like the harder it is to treat, this is what they mean by prognostic, the harder it is, it kind of potentiates the disease is what they're getting at with that. I want you to understand this. There are phases of schizophrenia. Prodromal, this is when it starts to, it's kind of that you consider it the onset or mild. Maybe patients just aren't feeling right. Something seems strange. They feel like their thought patterns are a little bit off. Maybe they seem like an odd bird or quirky. And it's a change. They haven't seemed like this before. So maybe people real close are starting to notice something, but no one can put their finger on it. This is when people may be self-medicating with drugs and alcohol, which can then potentiate the problem. But this is that sort of beginning phase. Then it goes into an acute phase. And when someone has an acute episode, they are hallucinating, they are delusional, they are showing signs of psychosis, they have lost touch with reality. Then you work on a stabilization phase. And so now you're trying to diminish the symptoms. You're trying to use some antipsychotics to stop hallucinations, to stop delusions. You're trying to get them back to a level of functioning where they can function in society, and they may be in some sort of outpatient, intensive outpatient. They may end up hospitalized. Many do end up hospitalized, especially if they're having delusions that are causing suicidal ideation or possible aggressive behavior, or potential for aggressive behavior hurting someone else. And then you kind of get to this maintenance where a new baseline is established. And with many schizophrenia patients, that baseline is difficult and can be difficult to get back, back to sort of a normal functioning. It is an ongoing illness that really takes a lot of work to maintain maintain it, to be honest, because many people who have it don't really believe they have it. So we're going to talk about during the prodromal phase. One of the things that you would, someone comes and says, I have weird thought processes, something seems different, my family members keep saying I'm different. You're going to be looking for what we call positive symptoms, and I'm going to get into that in more detail. Negative symptoms. So positive symptoms you can help remember by positive meaning symptoms that you feel and have. Negative symptoms that are new. Negative symptoms would mean symptoms of a lack of something. Cognitive is more going to be in how your thought process is. If affective is going to be more your feeling. Positive, something new. Negative, something that's gone away that you're used to. Cognitive in your brain. Affective in your emotions. I love this picture. I added this because I think this is basically what I want to make sure you understand. So positive, you have new hallucinations, new delusions. You have that disorganized speech where there's not a lot of associative looseness. It doesn't make a lot of sense what you're talking about. It's hard for someone to follow you. Maybe bizarre behavior. Negative symptoms. You have a blunted affect. You're negative. You're not feeling joy, so lack of joy. You're not having a lot of thoughts. Ologia. Ologia? Maybe ologia. I'm not sure I say that. That evolution is that lack of motivation, not wanting to get up and get out of bed. Anhedonia is inability to experience joy. Your cognitive symptoms, inattention, impaired memory, poor problem solving, decision making, illogical thinking, impaired judgment. And then you have dysphoria, feeling just very hopeless, possibly suicidal, lack of joy. And then basically the big takeaway from this is, as a nurse, how do all these symptoms affect someone's ability to function? And when I talked about that piece of tape on the floor and that being mental health, we now have something that's taken us way off that line of mental health. How do you try to get someone back to where they can, live alone, hold a job down, contribute to society, maintain relationships? It is a very challenging disorder to do all those things. This just goes into more detail over what positive symptoms are. and it gives you lots of definitions. I want you to just go through these definitions. You will see them in distractors. You'll see them in questions. Write yourself notes. You're not going to have to come up with it and write it down. Hopefully there'll be something that will trigger the meaning for you. But I'm not going to read them all to you. I go through a bunch of these. This is how their speech patterns may be different. We've seen this in your clinicals, and I want you guys to kind of now think about when you think about some of those conversations you've had with schizophrenic patients. Have you seen this? Have you seen tangentiality? I think we've definitely seen that. We've definitely seen cognitive retardation. Definitely seen that passive speech. Ooh, I meant to make flight of ideas red. Definitely seen that. Um, Symbolic speech, very, very different. Um, Again, this is how their thoughts, this is those cognitive symptoms. Again, I'm not going to go through each one with you, but I think you can read through those. And this is, again, more cognitive, how they are perceiving the world. One of the most dangerous things if someone is having a command hallucination, that's going to definitely warrant inpatient because this is someone who's being told to, it is a very scary part of psychosis where they've really lost touch with reality and they're being told to do something, go kill someone, etc. And their behavior is going to be affected. These are all different types of behaviors. Waxy flexibility is super interesting. It's, let's say you take a patient's arm to take their blood pressure, and then when you're done, they still hold their arm up. It's very bizarre. Echopraxia is where they keep just mimicking your movements. We've seen impulse control, gesturing or posturing is just sort of sitting there with unusual expressions. And I see the gesturing or posturing sometimes in group where you just looking like someone just has a weird expression on their face, and they're just holding it. Definitely, we've seen boundaries. We've seen the motor retardation, and which is the opposite of motor agitation, which is that pacing, just pacing. Stereotype behaviors. Oh, I spelled that wrong. This would be if someone keeps going to open a door, but like never does it, and they just keep repeating, like grabbing the handle and backing up and grabbing the handle. It's like they're stuck on rewind and just keep repeating it. Catatonia, typically when you think of someone in a catatonic state, you think of them as just laying there like they're dead, basically. But it can also be an increase in movement where you see echopraxia and echolalia, which isn't on here. Echolalia is when they just keep repeating words. Either repeating, if you say hi, hi, that game we would play as kids, it give me that, or just repeating the same word. Negative symptoms, you guys can, oh, gosh, I meant everything that's full pointed should be red. I'm sorry. I'll do that on the ones I give to you guys. Affect. So negative symptoms from an affect standpoint, from your emotional standpoint, flat, nothing. Blunted, very similar to flat. Constricted, they only appear sad. Inappropriate, they're laughing even though you're talking about something serious, or vice versa. Bizarre kind of goes right in with that too. So those are affective symptoms. So we've talked about positive, negative, affective, and cognitive, and they can overlap. So cognitive symptoms. So this is how their brain is functioning inappropriately, and I'll let you read through that. So it's important to assess for depression in those affective symptoms because we know that these patients are at increased risk for suicide. The problem is trying to get them to do a self-assessment because they often suffer from what's called anosognosia. Anosognosia. Oh, sorry, you guys, I'm trying to say it. But basically, that's the inability to, you don't believe you're sick. You don't believe you're sick. So, how do you convince someone that they need to be inpatient because they don't believe anything's wrong with them? That is a really, really tricky kind of symptom to deal with because then they're paranoid and they think you are actually trying to hurt them. So basically, you're trying to set expectations. You're trying to maintain not being frustrated or fearful because sometimes you can have a patient that is dangerous. So you have to always, um, you know, approach those patients in the right function where you're not alone in a room. We've talked about this in clinical where the door isn't shut. You're always between the patient and the door. Often you're going to have someone else there in with you. These are other things you're going to look at with assessment guidelines. I'm just going to click through these because I think you guys can understand these. Obviously, here are some nursing diagnoses for positive symptoms. What are positive symptoms again? Symptoms that are new, that are present, delusions, hallucinations. What are negative symptoms? Symptoms that now no longer feeling joy, so you're losing symptoms. Okay, so those are symptoms are the feelings that go away. Positive symptoms are the new symptoms. And why is that important? When we talk about medications, you'll see how certain antipsychotics either treat both or one. And really, we need to treat both to hopefully get patients to be better. Whenever we look at nursing diagnosis, we look at outcomes. What are the outcomes we would like to see in these patients? So phase 1, in that acute phase, we want safety, always, always go back to safety, right? And hopefully start getting medication on board and working. Phase 2, as we stabilize them, we're trying to get that patient to not have that I can say it right. Let me look at it as I read it. That may help me. Anosognosia. I don't know. We try to help them understand their illness. We try to figure out what medications work for them, what dose works for them, what minimizes side effects for them, and help them to control and cope and kind of realize this is a new norm. Phase 3 really is preventing relapse. It is so hard with these patients because they feel better and then they stop taking the medication, or the symptoms to them, the side effects are worse than the symptom reduction. So really the ultimate goal is that they can achieve independence and have this satisfactory quality of life, but it can be hard. It can be hard. So hang on, I lost where I was. Interventions. What slide number are we on? Oh, geez, sorry. Okay, so planning, you guys know this. I'm just safety again in that acute phase. What are things that you're going to do as a nurse to plan for their care? So I'm going to let you read through that. How do we implement this? We implement this through evaluations, through psychopharmacology, right? We use medications, through support, through therapy, through setting boundaries in the milieu, through monitoring fluid intake, right? Remember that polydipsia, that's something we have to think about from a nursing standpoint, to how do we deal with aggression and look for safety? Again, always go back to that safety. What do we do to intervene? Medication. Help to build a trusting relationship. Help to find some community-based therapeutic services that may be able to help this patient. So all different things. Try to help this patient deal with hallucinations and delusions and how they can label those. Try not to support associative looseness. When they're not making sense, while you don't want to blame it on the patient, you want to let them know they're not making sense by saying things like, I'm having trouble following you. Because really, they need to be able to identify when they're having associative looseness if they're going to function. So the next few slides talk about medications. There is lots of pages on this. I don't want you to get too crazy. What I want you to take away is that antipsychotics can take up to 2 to 3 weeks to achieve the efficacy that we want. There are first generation, second generation, and third generation. And then we have these injectables for short acting and long acting. And why would we use injectables? Because compliance is a huge, huge issue with patients with schizophrenia. And so